Good morning, Down Syndrome Association, New South Wales. This is Trevor Parmenter with greetings particularly to the board and the chairman, Haley Warren, and your CEO, Jennifer Evans. I'm sorry I cannot be with you in person, but I'm assuming we're all beaming in on Zoom, the aftermath of the pandemic, which has changed our lives considerably. It's 40 years since the beginnings of Down Syndrome Association New South Wales. It takes us back to 1980, just about 4 years after the first early intervention program for people with Down syndrome was commenced at Macquarie University by Dr. Bernie Thorley and the late Maura Peterson. Assisted ably by people such as Sue Cairns and Robin Trelaw, both of whom are still working in the field. That was a momentous development based on the spectacular work that had been done by the University of Washington in Seattle. And we at that time brought out 2 of their senior staff to help us set up that program. 1980 was just 6 years before the landmark Disability Act of 1986, which brought about significant changes in the way not only we viewed people with disabilities, but gave a greater impetus to moving people into the community. I want to address some of the achievements and some of the challenges that we still have to face for people with Down syndrome in today's society. I'm going to share with you some slides which will illustrate Sorry, we seem to have there we are. So the title of my talk is 40 Years On, Much Achieved, Much to be Done, Challenges Ahead for People with Down Syndrome and Their Families. I want to address the lifespan of people with Down syndrome, starting with early intervention, moving through to at the point of their birth, and subsequently they face complex health needs. How have we reacted to those? We move on to inclusive school education, which includes both preschool and primary and high school, transitioning from school to work and further study, working in open employment settings, living semi-independently, the development of friendships and relationships, and towards the end of their lives, the question of early aging needs. So let's look initially at where we are at early intervention. I've mentioned that breakthrough that we had in the 1970s, 1980s, when the outcomes of early intervention programs became well established. In fact, some of the gains that we'd made with the Macquarie cohort was such that when those children entered primary school and various academic skills, they were almost at grade level, the same grade level as their peers. Disappointingly, much of that washed out as their school years progressed. But coming back to the early intervention itself, what are the challenges now? Well, I believe the challenges are basically around the way early intervention is funded by the NDIS. I'm not sure whether quality controls of the providers are adequately looked at. I'm not sure the types of programs that are currently being offered. I know in many parts of the world there is still what I would call the clinical model being offered, where a family takes their newborn child with Down syndrome or in their very early years to a clinic. The therapist gives some examples of the sorts of things that can be done. There's some therapy done. But then it's very much a matter of come back next week or come back later in the week and we'll have another session. I'm wondering whether the current early intervention programs are mirroring the collaborative process that we had between families actively involved. I know it put a lot of pressure on families, but the gains that ensued from family intervention in partnership with the clinical staff produced much better outcomes. So I think we still should watch this space and monitor the way the NDIS is funding early intervention programs for your sons and daughters currently. We've come a long way in recognising and providing for the complex health challenges that a child born with Down syndrome presents. In fact, presents right throughout their lives. But in that early stage of life, some of the challenges are quite complex. It gives me some sense of pride that my former centre, the Centre for Disability Studies, or then it was what it was then known as the Centre for Developmental Disability Studies, initiated one of the first special clinics, health clinics for people with Down syndrome. That clinic is still running at the Royal Rehabilitation Centre once a week, or twice a week actually. I'm not sure whether it's still targeting specifically a session for families with Down syndrome, but that facility is still available. As is the facility at Cremorne, the second health centre that was opened under the auspices of CDS. That is now being conducted under the auspices of the New South Wales Department of Health. And luckily, we now have further clinics, similar clinics opening across the state. And there are some efforts being made to have outreach to the rural areas of the state. We need to keep watching this space because I think the people who are most disadvantaged are those in the rural and remote regions of New South Wales. And I think advocacy is still demanded for your association to keep monitoring the progress of those special clinics because they are still desperately needed. Many of you will recall the battle we had to even get the New South Wales Department of Health to admit that people with developmental disabilities did have a special need for extra help with their health, their complex health needs. I believe we still have problems when we admit people with Down syndrome to hospital. There are problems surrounding communication skills, whether the emergency doctors are skilled in recognising some of the problems, particularly those who cannot communicate well. So again, watch this space, and your advocacy in this area is still very much needed. Now, the catchword for some years has been inclusive education. It's some pride that I helped develop one of the first so-called integration programs for children with partial vision way back in 1965 at Northmead High School Partially Seeing Unit. But the progress on inclusive education has been fairly slow. I still believe there is inadequate support for children with Down syndrome who move into mainstream classes. The challenges for teachers are still there. There is a much better opportunity for teachers in training to get some special education input. But I believe the resources within the mainstream schools are still insufficient. And we need to develop models of inclusive education because I believe inclusive education challenges the very structures that underpin primary and high school education, because sometimes it's those very structures that need to be looked at, rather than the ad hoc approach to providing support. Some of it is still a teacher aide withdrawing the child for extra help, or the setting up of special units within schools. I think this is an area that still needs much more research and much more action on the part of both the public and private school systems. Notwithstanding that, some schools are doing a fantastic job, led usually by a principal who is always pivotal to the success of inclusive education, a principal who will restructure his or her school. The problems are particularly critical at the high school level. The transition process. I've spent much of my professional research life looking at this issue, and sadly I must say that we're still treading water. We're still short of good models of how we should transition children from high school into further study particularly, and into the prospect of training for work, particularly work that is not in sheltered employment or is not simply a day program where the young person generally does not have a challenging set of activities that they enjoy. The Department of Education has a good policy on transition, which I can share with you. I'll send it to Jennifer actually for transmission for you to look at. And you might well ask the question of your school, if you still have children at high school, just what their policies are and what their practices are in terms of making that transition process smooth and seamless into post-school training and post-school work. We have demonstrable programs that have supported inclusive research, inclusive employment. Job support is a classic example of how an organisation has placed up to 1,000 young people over the years into open employment with ongoing support. And that's one of the features that we lack at the moment in the various work programs that the Commonwealth through the NDIS is supporting. There is insufficient support to help people whilst they are in open employment. Some do require drop-in support regularly, and it saves them moving back onto the disability pension. Unfortunately, the way we measure success through the Australian Bureau of Statistics, using the International Labour Organization definition of open employment, which is working 1 hour a week, which is totally insufficient to be classified as fully employed. The figures, the unemployment figures for people with disabilities generally are terribly disappointing, and more so for those with an intellectual or a developmental disability. Their figures are even lower than the general disability population. And these figures haven't moved much in my lifetime over the last several decades. It's interesting that having a home of one's own is now a policy of many governments. It's certainly the policy of the NDIS. For instance, there is a contract which my former centre is currently working on, looking at different options for living, for accommodation, for people with disabilities generally. There are some very successful examples of people moving out, living on their own or living with peers, but again, with ongoing support. I know it's a very big challenge for those of you who are parents, the challenge of making the break from your son and daughter living at home with you and the possibility of them living independently, or I would prefer to call semi-independently. Again, watch this space. I think the NDIS is looking at this closely, Indeed, they also are looking at the employment options very closely as well. So both of these areas, your association should be watching very closely and having input through your advocacy arm. The research that my colleagues and I have done over several decades show that one of the biggest problems that people with disabilities, and particularly people with Down syndrome, face is in the area of building relationships with other people, satisfying relationships which are reciprocal. In other words, they're relationships where there are true relationships where each person in the relationship values the other person and wants to be with the other person. And again, I know there are many examples in your association where your sons and daughters have made wonderful relationships, but it's an ongoing battle. For loneliness is one of the characteristics of people, particularly those people with communication difficulties. So relationships are terribly important to a person's quality of life. It's a very big challenge when we move from friendships into more intimate relationships. I know it's a challenge for all parents when the day comes when their son and daughter decides to move and marry someone, to form a relationship with someone separate from their relationship within the immediate family. This is a challenge, but again, it's again a part of the inclusive society. Do we deny our children the opportunity for intimate relationships? Again, this is a challenge for your association to help families who are faced with challenges with their adult sons and daughters are wishing for more intimate relationships. Again, this is something your association may already be doing. And if so, I'd encourage you to continue that, because loneliness, again, is not a feature of a good quality of life. And moving towards the end of life, or the latter years of life, and as you well know, the opportunity for early aging, the early aging process is more prevalent among people with Down syndrome than the general population. You're also aware that some, not all, but some may contract early onset of Alzheimer's disease or dementia. And this provides immense challenges to families. It challenges also to support systems. I've just completed a fairly large study with colleagues from the University of New England, which I mentioned at the Health Forum last year. And the key result was that we must develop a seamless system throughout the person's life. Not a system whereby at some age, such as early onset of aging, when their aging needs are too high for the support agency that may have been supporting them for decades, then suddenly the challenge is there whether the person needs to move to a nursing home. I know many of your members have faced this challenge. They've shared their stories with me, and the anguish that brings about, and often simply because there's no other alternative. So we are urging in our recommendations, the main recommendation is we want a seamless system where the silos between aged care and disability care are broken down, so people don't have to jump out of one system into another, both physically and psychologically. It's disastrous for the person themselves to have to be set with a new set of support workers, often in environments that they have no control over, and leaving their former home behind. This is so tragic. And the final point, which I possibly did raise also last year with you, was the fact that we must be very cautious about end-of-life decisions. The COVID-19 has brought up the question internationally as to whether there has been some discrimination against people with disabilities because their disability is such that may render them not as be seen as valuable as other people in society. I've been party to a paper where we talk about the rise of the new eugenics, where professionals, some people in the community have the mistaken belief that the life quality of a person with Down syndrome is forever a bad one. And if the life quality is always going to be a bad one, do we need to expend as much in the area of health and education when their life quality is going to be so bad, irrespective? And that is the belief that many people still hold. And it's a belief that colleagues and myself are really challenging, that the life quality of people with Down syndrome and other disabilities can be equal to, and in some cases even better than, the life quality of their peers. And it's up to us, and associations like yours, to double our efforts to make sure that life quality, despite the issues and the problems that the syndrome present, we must redouble our efforts always to build that life quality that everyone in our society should have and should be supported to have, and not to be seen as being a diminished person. I'll leave you with those challenges, dear friends. Now, sorry again I cannot be with you, but all the very best for your annual general meeting and your deliberations over the next 12 months. Thank you so much.